So in today's episode, we are going to discuss about schizophrenia and its management. As usual, we'll start with a few multiple choice questions and then delve into the discussion and get back to the same questions again. Today's episode is divided into two parts. In the first part, we talk about the clinical features and the disease model of schizophrenia. And in the second part, we talk about the pharmacology and the management of schizophrenia. So this is your first question. Psychosis differs from neurosis in. What is the basic difference between psychosis and neurosis? Next question. Insight is lost in. Next question. The commonest hallucination in schizophrenia is. Next question. The commonest delusion in schizophrenia is. Next question. Hallucinations are disorders of what? Next. Delusions are disorders of what? Next. Which one of the following is not a symptom of psychiatric disorder? And the last question before we start discussion. Schizophrenia is caused by. So with these introductory questions, let us start our discussion on schizophrenia. Now, as we start talking about the core psychiatric disorders today, there are few terminologies that will crop up in our mind. So we will first talk about the terminologies that we commonly use in behavioral sciences and psychiatry. So the words like psychosis, neurosis, illusion, delusion, and hallucination are very commonly used in psychiatry. And we must have a very clear idea of what they mean. Psychiatric disorders were initially, in the early stages, classified broadly into two categories: psychosis and neurosis. And the basic difference between the two were, in psychosis, the insight and judgment of the person was impaired. In neurosis, the insight and judgment of the person was intact. So, to make it more simple, a psychotic person will not understand that the person is diseased, but a neurotic person will understand that there is some problem with that person. For example, a schizophrenic person is psychotic because she or he will not believe that she or he has a problem. She will believe that other people are creating problem in her life or his life. Whereas if a person has depression or anxiety, the person is more likely to think that something is wrong with them and therefore they are suffering from the distress. This idea that I am suffering, this sense of being in distress is lost in psychosis, whereas it is intact in neurosis. So broadly speaking, psychosis and neurosis has these following differences. In psychosis, the insight is absent and judgment and reasoning is impaired. These two are totally intact in neurosis. So in neurosis, insight is present and judgment and reasoning is also intact. In psychosis, contact with reality is lost, but contact with reality is present in neurosis. In psychosis, classically, delusions and hallucinations are present. In neurosis, like anxiety or depression, we do not get true hallucinations or delusions. And because of all these changes, in psychosis, the person may have a change in personality. But in neurosis, the personality doesn't change, only that the person is suffering. So, one of the most classical example of psychosis is schizophrenia. And a classical example of neurosis probably is anxiety disorder. So this is how psychosis and neurosis broadly differ. And since today we are going to talk about schizophrenia, we will be acquainting ourselves with the features of a psychosis. Illusion is a glitch in the sensory system. So for example, this kind of images are very commonly seen in the internet. If you look at this image, it seems that these blue dots are moving. Of course, they are not moving. So illusion is a false perception. It's a false perception of a real stimulus. And this happens because our sensory system itself has some glitches. Our brain tends to autocorrect various manifestations. And that is why illusions happen. Illusions can happen in perfectly normal individuals. Can you name a situation where we pay money to buy illusion? Yes, very good. In a magic show. So basically, a magician is an illusionist. And so it is not that everyone who is illuded by the magic is disordered. So illusion is a perfectly normal phenomenon. And illusion refers to a false perception of a real object or stimulus. So it is a false perception, but of a real object or stimulus. And when we use the word perception, we essentially refer to sensation. So perception means anything that we can achieve through the sense organ. So all the major senses that we have in our body, like vision, like hearing, like taste, smell, touch, pressure, all are perception. So sensation is also known as perception. On the other hand, when we talk about delusion. A delusion is not as simple as illusion. A delusion is not a perceptual disorder. It is a disorder of thought. So a delusion is best described as a disorder of thought. And what kind of disorder are we talking about? A delusion is a firm, fixed, false belief. It is a firm, fixed, and false belief. and this cannot be easily removed by logical reasoning. This is known as delusion. So you strongly believe in something which may not be true. There are certain delusions that may be cultural, and therefore that is not considered to be a disorder. For example, the cultural belief in demons or gods. But there are certain kind of delusions that are not culturally inherited and therefore may be considered to be a disorder. It is not learned by someone but developed by someone. So common examples of such delusions include paranoid delusion, also known as persecutory delusion, where a person believes that other people are trying to harm that person. A delusion of reference, where a person thinks that everyone is talking about him only. A grandiose delusion, commonly seen in manic phase of bipolar disorder, where a person thinks that the person has a lot of power or money. So a person thinks that they have a lot of power or money, and often the power may be supernatural. Erotomanic delusion, where a person thinks that another person loves them, but actually maybe the two person don't even know each other. So it's a false belief of being loved by someone. And often that someone is such a bizarre concept that either the person doesn't exist or the person has never met. We have delusion of control, where a person thinks that he or she is controlled by some entity. That can be a person, that can be a machine, that can be the aliens, that can be any other supernatural power. So it's a delusion of being controlled by an entity. That can be human or non-human. Another common delusion is delusion of jealousy, where a person feels that the partner is cheating on them, although there is no proof for that. So the person is constantly jealous and thinks that the partner is cheating on them. We have very two special type of delusional disorders known as the Capgras syndrome and the Fregoli syndrome, also known as Capgras delusion and Fregoli delusion. These are very interesting cases but very rarely seen. In Capgras syndrome, the person thinks that all the people around have been replaced by imposter. So people have been replaced by imposters. That is, the person can identify other people, but then thinks that some other person has put on makeup to become or look like that person and has presented themselves to this person. So, like the person has changed from inside, but from outside, the person is identifiable. This kind of a belief that all people are replaced by imposter is Capgras syndrome. It can also sometimes be seen in complex partial epilepsy. Fregoli syndrome is somewhat opposite of this. Here, the person thinks that the same person is dressing up like different people and presenting to him. So it's somewhat like you can say, as the literature in a series of unfortunate events flows. So how Count Olaf would present himself in different ways repeatedly. So if that really happens, or if the person thinks that such a thing is happening, that is the Fregoli phenomena. The person thinks that one particular person or a group of people are repeatedly dressing up and imposing like other people and presenting to themselves. That is a Fregoli syndrome. So one person or a group of person is repeatedly imposing as other persons. So these are some of the common types of delusion, and not all of them are seen in schizophrenia. Paranoid delusion or persecutory delusion, that is a delusion of being harmed, is the commonest delusion in schizophrenia. Hallucinations are disorders of perception, that is, they are disorders of sensory organ. Because there are five major senses, so there are five major types of hallucination. If a person hears something that is not there, or for which there is actually no stimulus, then that is auditory hallucination. So auditory hallucination happens to be the commonest hallucination in schizophrenia. Whereas visual hallucinations are usually more common in organic brain diseases. For example, in Alzheimer's disease. Tactile hallucination is sometimes seen in people using cocaine. Olfactory hallucination, that is smelling something that is not there, may be sometimes present in schizophrenia. It can also be present in the aura phase of either migraine or complex partial epilepsy. Gustatory hallucinations are relatively much less common. They are sometimes found in complex partial epilepsy. So therefore, in schizophrenia, the commonest hallucination is auditory. Auditory hallucination is sometimes divided into three categories based on the manner in which the hallucinatory voice is speaking. Sometimes it is known as first person auditory hallucination, when the hallucination speaks as I, me, or we. This phenomenon is sometimes also known as thought echo, as if the person is hearing their own thought. It can be called a second person hallucination, where the hallucinatory voice is speaking in a language like you. And sometimes this voice is telling the sufferer to do something, in which case it is known as a command hallucination. Another type of hallucination, which is typically characteristic of schizophrenia, is third person hallucination. And in third person hallucination, the patient feels that the voices are speaking about him or something else, but not directly to him. They are speaking amongst themselves. So they are referring to the person as he, she, they, or it. Sometimes the voice can just keep on describing what the other person is doing. And that kind of a third person hallucination is called running commentary hallucination. And this is very characteristic of schizophrenia. If a person have running commentary third person hallucination, that is definitely schizophrenia. It's a diagnostic criteria. So these are the common types of perceptual disturbances that we see in psychiatric diseases. And out of all these, the most common hallucination that we see in psychiatric diseases is auditory. And the most diagnostic auditory hallucination of schizophrenia is the third person running commentary hallucination. So I hope up to this is clear to everyone. So are the basic concepts of delusion, hallucination, and illusion clear? Okay. So now we come to the diagnostic criteria of schizophrenia. What I am presenting here is the DSM criteria by the Diagnostic and Statistical Manual. There is also an ICD criteria by the International Classification of Disease. They are more or less similar. They may look different, but the content is more or less similar. So how do you diagnose clinically a patient with schizophrenia? So there are five criteria that have been mentioned: delusions, hallucinations, disorganized speech, a speech that does not have much meaning or content, catatonia, I'll explain what is catatonia, and avolition and emotional flattening, which I will again explain. Out of these five criteria, if any two symptoms are present, for 1 month, then you can describe the condition to be schizophrenia. And it is expected that the two symptoms, out of the two symptoms, one should be from 1, 2, and 3. Serial number 1, 2, and 3. Any one should be from there because they are more diagnostic of schizophrenia. So we already know what is delusion. We know that delusion are disorders of thought. We know that hallucinations are disorders of perception. Disorganized speech means that the content, the relevance, the coherence, or the flow of the speech, any one or more of these can become abnormal. Catatonia is a motor symptom. When a person experiences catatonia, the person becomes rigid, so the muscle tone increases. Speech decreases. Movements decrease. And the person stands like a statue, which is also known as waxy flexibility. So you can make the person stand in any position for a long time. Essentially, all motor phenomena decrease. That is why catatonia is also described as a negative symptom. Why negative? Because there is reduced movement. A similar negative symptom is avolition and emotional flattening. Volition means voluntary activity. Avolition means lack of volition. So the person doesn't want to do anything, just sits at the corner of the room. And emotional flattening means that there is no emotional expression. So if you say something funny, the person doesn't laugh. If you say something sad, the person doesn't cry. There is no emotional response and there is a mask faces. This is known as emotional flattening. These are also examples of negative symptom because it represents absence of something, absence of volition or absence of emotional response. So if a person has any two out of delusion, hallucination, disorganized speech, catatonia, and avolition and emotional flattening, at least for a period of 1 month, then you can diagnose the condition as schizophrenia. Often the person has a prodrome. Prodrome means a premonitory stage where not all features are present, but the person is feeling uncomfortable. And often that will precede this period of schizophrenic symptoms, and that can be as long and as short as, say, 6 months. Based on the clinical features, schizophrenia is sometimes classified into 4 categories. When the predominant feature is paranoid delusion, that is a fear that someone is going to kill me or someone is going to poison me or someone is going to harm me, when that is the primary feature, then that kind of a schizophrenia is called paranoid schizophrenia. And this is the commonest subtype of schizophrenia. Remember, paranoid delusion is the commonest delusion. So paranoid schizophrenia is the commonest schizophrenia. If the predominant feature is disorganized speech or behavior, that is, either the speech doesn't make any sense or the person has socially inappropriate behavior, like the person is moving around without wearing clothes in the open street, or the person is picking dirt from the floor and eating that. When this kind of behavior are seen suddenly in a person, that is a disorganized behavior. So when disorganized speech or behavior become the dominant features, then that kind of a schizophrenia is called disorganized schizophrenia. But of course, with this, the other diagnostic criteria are also present. If catatonia, that is stiffness of the body and waxy flexibility, become the most important criteria, then that is called catatonic schizophrenia. But sometime you will see that the features are mixed up. The same person may have more than one type of feature. In those cases, it is known as undifferentiated schizophrenia. So these are the predominant types of schizophrenia through our classification. Apart from this, there are also some other subtypes, but these are the most important subtypes of schizophrenia. Up to this, is this clear to everyone? So what causes schizophrenia? The schizophrenia is explained with the help of certain neurotransmitter hypotheses. For example, the dopamine hypothesis. It is assumed that increased dopamine in certain parts of the brain can lead to schizophrenia. So what are the different dopaminergic pathways in the brain? Let us quickly review. In the brain, dopaminergic pathways are present in the cortex, which is known as the mesocortical tract. So you can see that from the ventral tegmental area, a large red color projection of the dopaminergic tract is going through and through the cortex. And this pathway has been known as the mesocortical dopaminergic tract. The mesocortical tract is responsible for our thought, action, emotion, etc. and behavior. A smaller tract projects towards the limbic cortex. And as it projects towards the limbic cortex, this blue area is therefore known as the mesolimbic tract. The mesolimbic tract is also important in regulation of our emotions. We have the nigrostriatal tract that plays important role in movement, as we all know. So the nigrostriatal tract from substantia nigra to the striatum is responsible for planning of movement in the basal ganglia. And a small dopaminergic projection moves from the hypothalamus to the pituitary, which is called the tuberoinfundibular tract. This tuberoinfundibular tract regulates the release of prolactin. So in this tract, increased dopamine causes reduced prolactin. Now, schizophrenia is caused, according to the dopamine hypothesis, schizophrenia is caused when there is dopamine disorder in the mesolimbic and mesocortical pathway. The most common disorder that we see is that the dopamine concentration significantly rises in the mesolimbic pathway. So there is increased dopamine in the mesolimbic pathway, and that usually causes the features of schizophrenia. Due to some reason, as the disease becomes chronic, dopamine concentration decreases in the mesocortical pathway. And this leads to the negative symptoms of schizophrenia, like avolition, like catatonia, and other features. So, increased dopamine in the mesolimbic pathway causes delusion and hallucination. And reduced dopamine in the mesocortical pathway is responsible for the negative symptoms. Because most common features are delusion and hallucination, therefore the most common drugs that prevent the symptoms of schizophrenia, that is treat schizophrenia symptomatically, are all antidopaminergic drugs. But in very selective cases, we need to increase dopamine in the mesocortical pathway to treat the negative symptoms also, which we shall discuss later. So in the mesocortical pathway, the functions are mainly cognition and executive function. And if there is reduced dopamine here, that is, if there is a hypodopaminergic state, it leads to negative symptom, allogia, affective flattening, and avolition. On the other hand, if the person has excess dopamine in the mesolimbic pathway, that is hyperdopaminergic condition, then the person will have delusion, hallucination, disorganized thought, speech, and behavior. These are known as positive symptoms of schizophrenia because these are over and above the normal activities of a human being. The main aim in schizophrenia is to reduce the positive symptoms because they are most commonly seen in the patients, and they are done by dopamine receptor blocking drug, D2 receptor blockers. In some special cases, we need to elevate the dopamine in mesocortical pathway to relieve the negative symptoms. This is done by a special category of drug known as sulpiride or amisulpiride, which can increase dopamine selectively in the mesocortical pathway and therefore relieve the negative symptoms. Gradually, as more and more research is being done into schizophrenia, we are understanding that probably the change in dopamine is not the cause, it is the effect. A more fundamental cause is a change in the glutamate level in the brain. Discussion of this is beyond the scope of today's episode, but simply speaking, probably it is the increase in glutamate that indirectly causes an increase in the dopamine. So maybe it is the glutamatergic pathway which is the main culprit rather than the dopaminergic pathway. Now, again, we do not know what causes schizophrenia. Like most psychiatric disorder, it's very elusive and we are at a very beginning stage to understand schizophrenia. Certain ideas that have been introduced are that uh, it may be genetically linked. Proof of this comes from the fact that monozygotic twins have a 48% concordance rate, whereas dizygotic twins have only 4%, indicating that there may be candidate genes. It is seen through study that siblings of a patient with schizophrenia have a 10% chance of the disease, and if both parents have schizophrenia, child has about 50% chance of the disease. During birth, if there is an obstetric complication like hypoxic brain injury, it is seen that it can increase the risk of schizophrenia. Cannabis use during adolescence can increase the risk of schizophrenia. We have already discussed the neurochemical theories about glutamate and dopamine, and imaging studies like MRI scans have shown that schizophrenia causes a decreased cortical volume, particularly in the temporal lobes. But whether these are the effect of the disease or these are the causes of the disease is still not clearly understood. Because so little is understood about schizophrenia, so let us make a neurodevelopmental model of schizophrenia. The proposed model is like this, that the patient might acquire certain genes that cause an abnormal prenatal development or fetal development. This can be further promoted by obstetric complications and for some reason urbanicity, that is living in the cities, and obstetric complications like hypoxic brain injury. After birth, when the brain will subsequently mature, there may be some kind of synaptic abnormalities like pruning, there may be defective myelination or apoptosis of neurons. And by the time the child reaches adolescence, the prodromal symptoms of schizophrenia can start. This is further potentiated by certain triggers. During childhood, the intellectual, motor, and social skills may be impaired, and as the prodrome leads to early adulthood, the florid symptoms of schizophrenia might develop. Mean age being around 23 to 28 years. During adolescence, a precipitating factor can be stressful life event or psychoactive drugs like cannabis. And in the adulthood, there may be continuing abnormal plasticity or long-term potentiation of the neurons forming abnormal connections, which is called kindling, very similar to epilepsy. And this can cause progression of the disease of schizophrenia. This model is as vague as it can be, to be very honest, because it only talks about the risk factors that we have already discussed in the previous part, and it tries to put them together into a interlinked chain of events. And we are not very sure whether this is a correct model, and studies are being done more and more to understand the pathophysiology of schizophrenia. So with this, we end the first part, the genesis and the clinical features of schizophrenia. Let us try to answer the questions that we started with. So this is your first question. Psychosis differs from neurosis in. Yes, the answer is presence of hallucination. Insight is lost in. Very good. The answer is psychosis. The commonest hallucination in schizophrenia is. Wonderful. The answer is auditory hallucination. The commonest delusion in schizophrenia is. Yes, it is persecutory or paranoid delusion. Hallucinations are disorders of. Wonderful. They're disorders of perception. Delusions are disorders of. Yes, the delusions are disorders of thought. Which of the following is not a symptom of psychiatric disorder? Yes, illusion can be seen in normal individuals also. And finally, schizophrenia is caused by. So the best option out of these is high level of dopamine in the brain. That should be the answer. With this, we end the first section, and the second section is about the pharmacology and management of schizophrenia. I hope up to this is clear to everyone. So let's try these questions. Compared to second generation drugs, first generation antipsychotics have. Next question. Akathisia is caused by. Next question. Drug induced Parkinsonism is caused by. Next question. Neuroleptic malignant syndrome is treated with. Next question. Neuroleptic malignant syndrome can cause. Next. Drug-induced Parkinsonism is treated with. And the last question before we start discussion. Second generation antipsychotic having a prominent extrapyramidal side effect is. So let us start the discussion on the pharmacology and management of schizophrenia. We know that schizophrenia is associated with increasing dopamine in the brain. So all antipsychotic drugs are antagonists of D2 receptor, mainly in the mesolimbic tract and also in the mesocortical tract. Only in selected cases where there is a mesocortical dopamine deficiency, we use special kind of drugs. Because negative symptom is not so common in schizophrenia. They all have the same mechanism of action, that is, all of them block D2 receptor, and therefore they have the same kind of side effect due to D2 receptor block. Antipsychotic drugs are broadly classified into two categories: the first generation agent and the second generation agent. The fundamental difference between them is, in the first generation agent, extrapyramidal side effect like drug-induced Parkinsonism is very high. In the second generation agent, the extrapyramidal side effects are much less. That is the main difference. There is only one exception, that is the drug risperidone is a second generation agent, but it causes significant extrapyramidal side effect. Otherwise, the basic difference between first and second generation drug is that the first generation agents cause a high incidence of extrapyramidal side effect like Parkinsonism, and the second generation agents cause a much lower incidence of extrapyramidal side effect like drug-induced Parkinsonism. Now, the additional differences are second generation agents have prominent action on other neurotransmitters like serotonin, GABA, noradrenaline, glutamate. The second generation agents increase appetite and body weight, and that is why they have metabolic complications like type 2 diabetes mellitus and dyslipidemia. And because these are new drugs, we do not know whether they are very safe in pregnancy or lactation. However, because the second generation agents also act on serotonin and noradrenaline, they have very prominent mood stabilizing action. First generation agents do not have much mood stabilizing action. And the second generation agents, being new drugs, are more costly than the first generation agent. So to summarize this whole thing, first generation agents have higher extrapyramidal side effect but lesser metabolic side effect and mood stabilizing action. Second generation agents have lower extrapyramidal side effect but greater metabolic complications but greater mood stabilizing action as well. These are the basic differences between the first and second generation antipsychotic drugs. The first generation drugs include low potency agents like chlorpromazine, medium potency agents like loxapine, and high potency agents like haloperidol. Haloperidol is also available as a long-acting preparation that can be given once in 3 weeks or 4 weeks. Second generation agents include clozapine, olanzapine, risperidone, quetiapine, sulpiride and amisulpiride, and ziprasidone. Out of this, individual drugs may have some special properties. A very commonly used drug in clinical practice is haloperidol and chlorpromazine. Of the second generation agents, olanzapine is a very commonly used drug. Risperidone has a very prominent extrapyramidal side effect, whereas quetiapine has very little extrapyramidal side effect. Clozapine is particularly useful to treat resistant schizophrenia, that is not responding to any medication. But it is not used routinely because it has a problem of causing agranulocytosis. So the WBC count should be monitored during the therapy. Quetiapine has very low prevalence of extrapyramidal side effect. So it can be used in patients who have motor disorders. Sulpiride and amisulpiride, when used in low dose, they are useful to treat negative symptoms. And ziprasidone has prominent effect on the mood, and therefore they are often used in schizophrenia associated with mood disorder, also known as schizoaffective disorders. So in a nutshell, these are the properties of the drug, and all of them block D2 receptor in the brain. The adverse effects, particularly seen in the first generation agents, are like this. They can block dopamine receptor and cause acute dystonia. And acute dystonia presents with torticollis, that is bending of the neck. Although it looks very distressing, it can be easily treated with antihistaminic or anticholinergic injection. Usually a single injection cures the condition. These drugs can block the D2 receptor in basal ganglia and cause drug-induced Parkinsonism. Drug-induced Parkinsonism is treated by reducing the dose of the drug, adding anticholinergic agents like benzhexol or antihistaminic agents like promethazine, which have additional anticholinergic action. Akathisia is caused by adrenergic hyperactivity, probably beta-adrenergic hyperactivity. The person feels very restless and cannot sit in a single position. When this adverse effect occurs, apart from reducing dose of the drug, treatment is done with a beta blocker. Another very dreadful complication is tardive dyskinesia, where a person has involuntary movement of the tongue, lip, or eye. This does not respond to medication very well. However, some result has been obtained by using clozapine. So clozapine can be used to treat tardive dyskinesia, which is an involuntary movement of the tongue, the eye, or the lips. Additionally, some drugs may have anticholinergic effects like dryness of mouth. Some of them may have antiadrenergic effects, for example, postural hypotension. Some may have antihistaminic effects like excessive sleepiness or sedation. And one of the dreaded side effects of the first generation agent is neuroleptic malignant syndrome, which we will be discussing in detail. So up to this, is this clear to everyone? Now, neuroleptic malignant syndrome doesn't happen in everyone. There is a genetic predisposition. And this syndrome is very similar to malignant hyperthermia that happens with succinylcholine and halothane. So these patients have some kind of a mutation in the ryanodine receptor of skeletal muscles. So there is a problem with the ryanodine receptor of skeletal muscles. When these individuals are unknowingly given the antipsychotic drugs, also known as neuroleptic drugs, for some reason there is a irreversible opening of ryanodine receptor in skeletal muscle. And we all know that ryanodine receptor causes release of calcium ion. So this causes release of large amounts of calcium ion in sarcoplasm. This large amount of calcium in the sarcoplasm causes muscle contraction. Calcium activates the ATPase and therefore heat is produced. Calcium also activates proteolytic enzyme, so it causes lysis of the muscle, also known as rhabdomyolysis, that is skeletal muscle lysis. The muscle contraction leads to rigidity of the whole body. The heat production can lead to hyperthermia. And the lysis of the muscle or rhabdomyolysis leads to myoglobinuria. As myoglobin is toxic to the kidney, this ultimately leads to renal failure. So the treatment of neuroleptic malignant syndrome is totally dependent on this pathogenesis. It is best to avoid the drug if you already know that the person is susceptible, but sometimes it is not possible because you do not know. But once you see the phenomenon, you stop the drug. The ryanodine receptor can be blocked by intravenous dantrolene sodium. This is the specific antidote or drug of choice in case of ryanodine receptor anomalies like malignant hyperthermia or neuroleptic malignant syndrome. The excess rigidity of the muscle can be partly controlled by giving benzodiazepines. The hyperthermia can be controlled by physical cooling of the body by ice packs. And the renal failure has to be treated properly with diuretics or dialysis. However, of all this treatment, the most specific treatment is injection dantrolene sodium. So this is how neuroleptic malignant syndrome can present and can be treated. Is this clear to everyone? Okay. So summarizing the management, both pharmacological and non-pharmacological, of schizophrenia. When a patient is diagnosed with schizophrenia, you do a risk assessment. The risk of suicide, risk to others, and the risk of self-neglect. Consider the need of hospital treatment because the patient's judgment is impaired and may not understand that the person is diseased. Involve the family members and caregivers so that they can also understand the disease and be compassionate and caring. Antipsychotics are the mainstay of treatment. So it is not a disorder that can be treated simply with counseling. It requires drugs. If there is a problem with compliance that the person doesn't take drug, then a depot preparation can be given, like haloperidol decanoate injection. It can be given every month. Choice of the antipsychotic depends on the response and side effect. There is no general rule for that. If the person has partly recovered but is still experiencing delusion and hallucination, then cognitive behavior therapy may be helpful. And behavioral family therapy usually helps in creating good bond with the family, and the rehabilitation becomes more successful. So these are the strategies of management of schizophrenia. So this was the presentation. Let us start with the questions that we tried to solve before. So compared to second generation drugs, the first generation antipsychotics have, what will be the answer? Yes, they have higher occurrence of extrapyramidal side effects. Next question. Akathisia is caused by. Wonderful. It is caused by increased beta adrenergic hyperactivity. So answer is A. Drug-induced Parkinsonism is caused by. Very good. They are caused by block of D2 receptors. So answer is C. Next question. Neuroleptic malignant syndrome is treated by. Yes, the answer will be dantrolene. Injection dantrolene sodium is the drug of choice. Next question. Neuroleptic malignant syndrome can cause. Wonderful. The answer is D, all of the above. Drug-induced Parkinsonism is treated with. Very good. The answer is all of the above. And the last question. The second generation antipsychotic having prominent extrapyramidal side effect. Yes, very good. The answer is D, risperidone.